Alright, so topical and local anesthesia. Local is a direct application of anesthetic to the oral tissue. Specifically designed anesthetics can be applied directly to the tissues to provide topical anesthesia or injected into the tissues to achieve profound local anesthesia. And this is the one that we want in order to be able to work on teeth or do root canals. You need the injected type. Okay, so topical is just like Ambisol that you buy over the counter for teething kids. It's the same thing, benzocaine. Okay, just rub it on the gums and it works. You'll feel, get on your tongue and your tongue gets numb. So that's all it is. It's Ambisol basically. Maybe a little bit stronger percent or concentration, but it's the same thing. The numbing sensation only occurs on the surface of the oral mucosa. It does not affect the underlying tissues. Okay, so as soon as you break through, that's all we're trying to do. We're trying to minimize the sensation on the surface. To avoid this, because this is usually what patients fear the most, the needle. Okay, the primary use of topical is to avoid or minimize the needle stick. Can also be used for a tooth desensitization or to decrease the gag reflex during dental impressions. Okay, if you can get your, and the one you would use would be a spray, because it comes in different, and we'll show it when we do the lab. There's a spray that you can just spray it back there and it'll numb the palate, the back of the palate. If you try to swab back there, you're going to have fun. Concentrations, again, they vary, anywhere from 5 to 20%. Can be supplied as a gel, liquid, ointment, or a spray. Okay. So again, this is the one that you can spray in the back of the throat. Hurricane. Just have them open. Spray doesn't taste very good. But again, Hurricane. These are the ones that we have. I don't think it's that brand. I think we just have the generic Patterson brand. But there's all kinds of topicals that you can use. How do you apply it? Obviously, we need to review the patient's medical history. You want to dry the area, okay, with a 2x2 little gauze. Dry it, because if you put any medicine in fluid, what does it do? It dilutes it, so it doesn't work as good. So make sure the area is dry and put it right on the area and leave it there for about a minute. Okay, wherever we're going to inject, that's where we want it. If you don't dry it, then it doesn't work as good. Apply topical anesthetic using a small amount of anesthetic on a cotton-tipped applicator. And if you've seen how the girls do it here, they break off when you load a syringe, the back of the needle is a little plastic, like a little plastic vial, and that's what they use to get the topical, and they use those little back ends and put them in there. That's what they're using. They're recycling the material there. So you use either a cotton tip applicator. You can put it on a gauze like that. They put it into that little container so that it's not hitting the instruments, because you get this on the instruments and they get all slippery. So it just keeps it covered. But whatever way to apply it, that may differ from office to office. Placement of topical and local anesthetic injection sites. Okay, these you need to know. Okay. On the top, maxillary arch, topical anesthetics are placed in the following locations prior to the local anesthetic injection. Okay. On the top, we can do something that's called infiltration. Okay. The top, the bone, the upper bone, the maxillary bone is very porous. So we can, if we're doing just one tooth, here, if I'm just working on tooth number 5, I can just put my needle right next to it, squirt some numbing medicine, and it's going to penetrate the bone and numb it up. Okay. On the bottom, it doesn't work as well because the bone is dense, and you can go right outside the bone, but you're not going to get strong enough anesthesia. So on the maxillary, we can infiltrate, means just flood the area. Okay. ASA, anterior, and this is a hard area to teach. Every time we've done it, this is where the students get it really confused, and I don't know how to explain it any different. We're in the maxilla, okay, so upper, ASA, there's one main nerve, and it separates into 3 branches, and I'll show them to you right now. You got an anterior, middle, and posterior. Okay, your anterior branch is about your canine, your middle branch is about the front part of or the second premolar more or less, and then your third branch is way in the back behind your second molar. Okay, so it comes out of your brain, and then it splits up into 3 branches. Okay, so the anterior, superior meaning top, meaning your maxilla, so anterior front, superior meaning maxilla, alveolar means what? Bone. Okay, so anterior, superior, alveolar. Okay, just mesial to the maxillary canine. Okay, at the apex of the mucobuccal fold means at the apex of where you pull your lip out and as far up as you can go. If you put your finger up there where it stops, that's where you want to inject. Okay, anterior, superior, alveolar. Okay, middle, superior alveolar, it's the middle branch. Okay, at the apex of the maxillary second premolar in the mucobuccal fold. So yeah, so just a little bit behind. Okay, and then if you got anterior, middle, the back one is posterior, superior. Again, posterior, superior meaning it's maxillary, upper, alveolar block. Okay, so just distal to the maxillary second molar in the mucobuccal fold. So if you put your finger going to the back, behind your last molar, up in there, that's where we're going to inject. Okay? Questions on ASA, MSA, PSA? Okay? I'll show, I thought my picture was coming up. Nasopalatine. You guys remember your skull? Nasopalatine. The most painful injection I think that you can get. Right behind your front teeth in the incisive foramen. Okay? Incisive papilla lingual to your central incisors. That little bump you have right behind, right there. That hurts. No matter how you do it, it hurts. And you just got to tell the patient.
So why is it those marks that you have to do?
I'll show you right now. I'll show you a picture and then I'll answer that question. It'll make a little bit more sense. Greater palatine. You guys remember that? Palatine foramen. Distal. Kind of between the midline and the gum around the second molar in the palate. Okay, halfway between the gingival margin and the midline of the palate in the second molar area on top. These are all upper injections. Okay? Okay, so this is why those areas. Okay, here's your main nerve, the maxillary nerve coming out, and then it splits into a posterior, a middle, and an anterior branch. Okay? And you can see the posterior gets me, it'll get me the back, the wisdom tooth, the second molar, and it'll actually come down to the back side of your first molar. Okay? So if I'm working on your first molar, I've got to give a posterior, a PSA, and I have to also give an MSA because the mesiobuccal cusp will not be numb. You'll start cutting and the mesial part of that tooth won't be numb because it gets innervated by the MSA. Okay, so this is why we numb up here. If we were working from the canine forward, any of these teeth from the canine forward, we can numb up here. And all these are going to be numb. Okay? If we're doing the premolars, we're going to do an MSA. Okay? If I'm doing any of the molars, I'm going to do a PSA. Okay? PSA, MSA, ASA. on either side, left or right. You've got same thing, PSA, MSA, ASA. Nasopalatine, greater palatine. Okay?
A picture of that.
Do you have a picture of that?
Yes, I never seen
I
it.
know,
Me too.
that
Pictures.
helps.
I can email you guys that, if you guys want, or take a picture. Take a picture and forward it to everybody. Get a good one? You forward it to everybody?
I couldn't remember my
Maybe.
lock
I
myself
don't know, I
out.
have to find the group message again.
If you
I just
can, I'll
took it
do
off
it,
when I
just remind me.
Oh,
Okay,
my-
so, and you guys have this picture here, again,
So much stuff.
PSA
I lost everything.
behind the second molar,
Everything.
MSA, apex of the second premolar, ASA, apex of the canine. Okay, greater palatine and the incisal palatine or nasal palatine. What's the other one that we can do on top? That was the first one that we talked about. Anywhere on top, I can do, if I'm only working on one tooth, I can do what?
Inject it.
Infiltrate. Okay?
So
I
do
can-
all.
If I'm just working on tooth number 7, I can just, instead of giving a ASA and blocking the nose and everything here,
Got it.
Does that mean the birds too?
Oh my god.
then you can just infiltrate around any tooth to numb up on top. Okay, so which one would that one be?
That's definitely posted.
What shot would that be? Okay, we got the canine, we got a premolar and a premolar.
MSA?
Middle superior, yeah. Okay, the ASA would be canine and the anteriors. Middle is the premolars, and it may get a little bit of the canine. Okay, on the bottom, you can infiltrate, they say, but it doesn't work very well. Okay, so you can try going outside. On children, it may work a little bit easier because it's not as dense. Or on somebody that's got gum disease, you can maybe infiltrate and it may work. But usually if we're working on the bottom, we have to give a block. Okay, meaning we have to go to that nerve and numb up the main nerve. Okay, so inferior alveolar. Okay, only one. There's not an MSA, ASA, or PSA on the bottom. There's only inferior, meaning bottom. On top it's MSA, meaning what? Middle, superior, top. On the bottom it's just inferior alveolar. Okay? So the only difference on top it could be superior alveolar, but you just need to know where, because it's got 3 branches. On the bottom there's only one, so it's just the inferior alveolar. And you give it distal, superior, and slightly lingual to the retromolar pad. So that's where you're going to put your topical. I'll show you where it's at. So the retromolar pad is the little bump behind your second molar on the bottom. Okay, you've got the second molar and then you feel a little fatty tissue back there. That's the retro, meaning behind molar pad, behind the molar pad. And there's also a buccal injection. Okay, and that's given just distal to the most distal tooth in the arch. And all you're trying to do is numb up the gum tissue on the side, the buccal tissue. And then there's the mental, which is between the first and second premolars, anterior to the mental foramen. Remember on the skull, that little hole right here. Foramen means what?
Opening?
Yeah, perfect, opening. So there's a little, if you tap in this area at one point, if you hit the right spot, it'll give you a little shock. And that's where the nerve is. It's the mental foramen. And so you can go out there and inject about 3/4 of the carpule, and you gotta push it into that foramen. Because it's not gonna penetrate, you gotta force it into that foramen to get the nerve that's coming from the premolar forward. Sometimes I'll do that if I'm working on an anterior tooth and I don't want to numb the tongue up. I just squirt there and just push and see if I can push some into that foramen, and it works. Okay, so here is the nerve. What's this called? Do you guys remember? Yes, coronoid process. And this guy?
Good try.
Condyloid process. Good. And so here's the nerve coming out from the skull and goes into, this may be an artery, I don't know, but it's going right into that, into the jawbone right there. And that's why when we inject, we grab the jaw and we try to split our fingers. We try to kind of hit a bullseye between our fingers, and we're trying to get into this area. We don't normally hit it. Sometimes we do hit it and the patient goes, ow. They'll feel like a shock, kind of like a 9-volt battery, because you nick that nerve with your needle. Okay, so there's the skull. Again, that's where it's coming out of here, and it's going to go in right there. So we're shooting for that area and just flooding the area with anesthetic before it goes into the jawbone. And that's where we block. So that's called the inferior alveolar block. Okay, the top are anterior superior alveolar block, middle superior anterior block, or middle superior and anterior superior alveolar block. Okay, and that's what it looks like in the mouth. Here's the thumb, and so you're going right in that little crevice right back there. Try to split your thumbs. Here's the buccal. Just buckle to the most distal tooth. You just go down till you hit the bone and inject a little bit. And here's the mental, between the two premolars on the bottom. Volunteers? Volunteers. Okay, so again, in this picture you guys have, so inferior alveolar, mental, and buccal. Okay, so that's where to apply the topical. Those are the positions you're going to apply the topical. So the local anesthesia means that we're injecting underneath. So loss of sensation localized to a specific part of the body. The ideal properties of the local anesthetic is that we inject, and within a couple minutes we're starting to get numb. Or you should be. So it's got rapid onset. It's got long duration. You get anywhere from 1 to 4 hours. Some medications out there can give you up to 7 or 8 hours of anesthesia.
What would you need that?
After like gum surgery or something, and you want the patient to go home and be comfortable after pain or surgery. Reversible means it's going to wear out and you're not going to have irritation. And the toxicity is low. Okay, you can give enough medication without too much problem to the patient as far as toxicity is. Okay, so rapid onset, it has long duration, it's reversible, and it has low toxicity. The other thing, it's got very few people are allergic to it. Low incidence of allergy. If somebody's allergic to it, it's probably to the preservatives that are put into the medication, but it's usually not an allergy to the anesthetic. It's got about 1.5 years of shelf life, and it's fairly inexpensive. The other thing, vasoconstrictors, we'll talk about them, are added to it because it allows us the medication to stay in the area longer. I think you need to know this. Yeah, you need to know some of these. Concentration and dosage. Okay, this is what's important, especially when we're dealing with kids. I think Dr. Cervantes went to a course last month, I think, where they talked about a case in California who little kid died because of toxicity. They gave him too much anesthetic, and they didn't realize it. Okay, so it's, I mean, it is, when we're dealing with adults, I mean, you can, I've seen, 10, 15 cartwheels sometimes on a big, heavy, and usually you're okay. I probably wouldn't. I probably, if I can't get them numb, with 2 or 3, and I'm saying, hey, not my day, we'll bring you back another day. I just don't feel comfortable just injecting. Now sometimes when you're doing surgery, like full mouth extraction, you're going to give 5, 6 cartwheels on an adult patient, and you're okay. On a kid, especially, 30, under 50 pounds, you're going to give maybe 1 cartwheel. You start, if I can't get them numb with 1 cartwheel, if I have to give a little bit more, I start getting a little nervous. I say, let's bring you back another day, or I refer them out for sedation or something. On kids, I don't usually use more than 1. Maybe 2 if I'm doing extractions, 1.5, maybe 2 on a little bigger kid. Little tiny kids, half, 1 maybe. The main ingredient of the cartridge is the local anesthetic, along with sodium chloride, which is salt water, distilled water, vasoconstrictor, and preservative. The percentage of the anesthetics, again, vary from 2% to 5%. And this is the percent that we have to worry about when we anesthetize. The label on the cartridge lists the anesthetic and vasoconstrictor percentage. So, and you look at them, and there'll be different colors and there'll be different numbers, and you have to pay attention, especially when you have a doctor that's working fast, going from room to room to room. You have to look at the medical history, and if you load the syringe, make sure that you're putting the right cartridge in there, because if the doctor gets in there fast and doesn't realize, and you put the wrong one in there, could be some problems. Cartwheels, they contain about 1.8 milliliters. Okay, that's how much liquid is in the little vial. So it's not a lot. It's less than half a teaspoon. Dosage is dependent upon type of anesthetic. Okay, there's depending on you're using lidocaine or bupivacaine or carbocaine, you're going to vary your dosage. And also, if it has a vasoconstrictor, we'll talk a little bit about that right now. The area that you're going to numb up, the size of the patient is the biggest one. Okay, a little kid or a 90-year-old grandma, you're not going to give 10 cartridges to. The health of the patient is the other thing. Okay, why do we need duration of anesthetics? Because we got to keep the patient comfortable throughout our procedure. And what makes it stay in there? The duration varies significantly between the types and the concentrations of anesthetics. The short durations, usually 10 to 30 minutes without a vasoconstrictor. Vasoconstrictor, again, it basically shuts down the blood supply to the area, and so the anesthetic stays in that area longer. Intermediate, you're going to get about 60 minutes with vasoconstrictor. Long, you're going to get about an hour and a half of pulpal anesthetic, about 60 minutes to 5 hours of soft tissue, and this is probably what we use. Long, the lidocaine with epinephrine, you're going to get about an hour, hour and a half of being able to drill on the tooth, but when the patient leaves, I'm still way numb. And that's why when you're numb, when you leave, you got to wait 2 to 3 hours before the numbing wears out from your lip. That's what patients hate. Okay, the vasoconstrictors is what's added to the anesthetic so that it stays in the area longer. When you give an anesthetic, you're going to get dilation of the blood vessels, meaning all the blood vessels are going to open up, so there's going to be a lot of flushing of blood. I mean, there's going to be blood going in through that area fast. So if you don't have a vasoconstrictor which shuts those down, the anesthetic isn't going to last. Okay? You're going to inject, and after 10-15 minutes, if there's no vasoconstrictor, or half an hour, it's gone. And if you need something that lasts longer, you've got to have epinephrine, which is the vasoconstrictor, to shut that blood supply so that it stays there longer. Okay? If it washes out too fast and it doesn't last, and you still got to work, guess what? You got to give them more. And then you work, and then it works out, and you got to give them more, and that's where you can get into toxicity. Okay, so you want something that's going to stay in that area and will give you the proper working time with 1 or maybe 2 carpules, and that's it. Okay, hemostasis, again, that's what the vasoconstrictors do. Epinephrine constrict blood vessels and cause less blood flow to the injection site, which again gives us more time to work. And if it does that, then you give less anesthetic, so there's less risk of it being toxic. Cautions of epinephrine use. Again, epinephrine is like adrenaline. Okay, if you're walking down the street and you see a rattlesnake right there, and your skin just kind of goes, and all your arm hairs kind of go like that, and everything goes, and you start breathing real fast, and your heart starts pumping real fast. That's like an epinephrine rush. That's your fight or flight that they call it, reflex. Epinephrine is the same thing. Okay, so in your body is adrenaline. That's your natural epinephrine that you have. If you get scared, you get an adrenaline rush, and your heart beats faster, your blood vessels dilate, your eye pupils dilate, because you're ready to either fight back or run. Okay, epinephrine is the same thing. So what is it that you have to caution when you use these medications? Patients with high blood pressure, any cardiac conditions, okay, hyperthyroid, they already have a fast metabolic rate, concentration of vasoconstrictors. The higher the ratio, the lower the anesthetic content. Okay, so these 3 are the ones you gotta know, okay? Yeah. So, and those are the ones you have to pay attention and not load don't load the syringe, leave the carpules out so that the doctor knows which one he wants to use. Okay, if there's any question, don't load the syringe, let the doctor, if he comes in and says, oh, why isn't my syringe loaded? Oh, I just wasn't sure on the medical history, so let him choose. Don't load something if you're not sure. Because again, if it's a fast-moving doctor, he'll get in and he'll just go in there and shoot. And if you've got the wrong one, it may not be good. Okay, so the concentration of the vasoconstrictor, the higher the ratio, the lower the anesthetic content. So 1 to 20,000, 1 to 50,000. This is the one that we mostly use here, 1 to 100,000. And then there's 1 to 200,000. And all these are color-coded, okay, and it'll say right here. Here's 1 to 50,000. Epinephrine is 1 to 100 is the red. This is the one that we use again. And you'll see on the carpule, it'll have a red band on it. So on a 1 to 50,000 epinephrine, it'll have a green band. These will have a red band. These will have a blue band. Okay, so again, they're color-coded. You just have to know what you're loading. Again, these will go over fast because it's kind of repetitive of what we already went through. Okay, local or infiltration, again, maxillary teeth, you go right outside the tube. Okay. Nerve block is when we need 1 or more or 2 or more teeth. We're going to try to get that main branch so that we numb up not just 1 tooth, but 2 or 3 teeth that we need. Okay, so the nerve blocks. So a nerve block is when you're trying to numb up more than 1 tooth. Like on the bottom, we're trying to numb up If we inject the block way back here, we're getting all the lower jaw on this left side. So even though we're working on tooth number 24, I'm numbing up back here, I'm numbing up, 18 all the way to here. Even though, because I'm getting the block way back here in the main branch. Okay.
And when you get that one, that's when it gives like a shock.
If you hit the nerve, yeah. That's usually the nerve that, you can get it anywhere if you hit it, but it's harder. I don't think I've ever gotten anyone get a shock on top. But on the bottom, every 1 in 100 patients that I inject, sometimes you're just really close or you nick it, and you go, ow! What happened? Oh, I felt a shock. And it's like, you clipped it with the needle.